we are going to switch to Zoom because I don't have to let everybody in constantly in and out throughout the meeting, and then it automatically will record as well. I'll send out an email afterwards, instructions, but I'm going to share a screen because what we've done is we have started a YouTube page where we're just going to upload all these videos to. And that way there's no problems, because sending out the link last week to the one that actually did record some audio, that one didn't work either. So we're going to keep just uploading everything at the end of each lecture. The other thing we're going to do today is, instead of doing quizzes at the end, kind of had the arrows pointing to everything, I'm going to take, I don't know if you can see this Word document. Can everyone see that? But I have a Word document of a quiz. I'm going to turn into a Google quiz, and I'll send that out so you guys can actually test yourselves. So let me, you weren't able to see that document. That's all right. I'm just going to get into the PowerPoint here. And I'm going to share this here. All right. Can we see? Let's see. So basically what we're going to do is we're going to go through anatomy just like we did on the x-rays, but we're going to go through on an MRI. So we just need some volunteers throughout the process to be able to be the people we're going to identify. But we're going to cover it so that way you know this detail. When we're looking at MRIs, it's really difficult to understand what's pathologic until you know what's normal anatomy. So this whole session here is just going to be T1 images because that's best for anatomy instead of looking for fluid on T2s. So does anybody want to start here? All right, if not, we're going to go through a few things. So what I can do is I can actually annotate here. So first we want to figure out, when we're looking at the anatomy of the leg, is this, I mean, you can type it in or you can say it, is this going to be a axial, coronal, sagittal image? So this is actually going to be an axial. We're looking down the leg. Good. We have one bone here. Let me change the color. What bone do we think that is? Good. Tibia. So we have our tibia. And then right here is our fibula. So anytime we're going to figure out what anatomy we're looking at, identify your bones first. If we're looking in the leg, do we think we're close to the ankle joint or up near the calf? Good, up in the calf, good. This was kind of, if you were watching the Friday dissection, Dr. Clardy made his incision right through here, basically. And this is everything that he was showing us. When you actually see the septa back here, we see muscles. What do you think the most posterior muscles are going to be? There's two of them. Good. Gastroc-soleus. Good. If you see the septa in the middle, we have our two heads of the gastroc, and we know those cross the knee joint, right? So it gets a little bit more difficult to discern all these exact muscles in here. But what we do know in general is if we find these septa like this, we know that we're going to see what compartment would this one be. Anterior compartment, good. You're going to have some lateral coming off the fibula, which would only be one muscle. What would be the muscle coming up off the fibula that high? Peroneus longus, good. And then all in here is going to be your deep posterior compartment. And remember from the lab when Dr. Clardy grabbed the one that's the most lateral? This one was your FHL. Good. So it gets a little bit easier as we go a little bit more distal, but very, very rarely are we looking this high up in the leg for anything. When we're looking at MRIs this high up in the leg, what we actually may be looking for is an abscess. Sometimes we get these infections that track up the tendons and form this deep abscess. So in that case, you wouldn't see this normal healthy musculature there. Oh no, I gotta clear it now. Okay. Anybody want to do this one? Now we're getting more into what we're going to look at on a regular basis.
Yeah, I'll give it a try.
Okay. So I'll help first by what bone is this one?
Tibia.
Good. Tibia, and what's here?
Fibula.
Good.
Yeah.
So when we see this, we know we're getting closer to the ankle joint, right?
Mm-hmm.
So these are the only two bones though. So what we can actually see, unlike the previous image, we can see everything start to disperse out into their own little compartments. Oh, sorry. So when we look back here, what are we looking here?
Sorry, you cut out. When you look back here, what?
When you see what I just circled, can you see in the back here?
Yes.
Okay. What do you think is in that compartment, or what are we looking at anatomically?
So I see the darkening of the Achilles tendon most posteriorly.
Okay.
And then in front of that would be maybe the tapering of the gastroc.
Okay. And then what else? What other muscle comes there?
Soleus also.
Good. And you can see right here where the septa is, the remnants of the two gastroc heads, and then the rest of it's the soleus in here.
Sure.
And you were right. Any tendon is going to be nice and black, and the Achilles is going to be thin at this part because everything is coming together before it really thickens. So if that's your superficial posterior group, where do you want to start next? You want to go deep, or do you want to go lateral or anterior?
Let's go lateral.
Okay. So if we're looking laterally, here's a nice little septa here.
Mm-hmm.
So what do you think's going on out this way?
So those are the
able to draw on
peroneals.
your end? Because we tested it yesterday. If you want to draw, you can.
Ooh, let me see. This is my first time using Zoom, so I may have to take a rain check on that. But
Dr. Clardy, how were you able to annotate on your end yesterday when I was doing this?
So I'm on my desktop now. Yesterday I was on my phone and it just had on the bottom like a little pen.
Oh, okay.
I'm trying to find it on the desktop. I don't see it.
We'll skip that.
I don't see a pen. I just see like reactions, chat.
There could be a view options button, and you can click annotate on the top.
Oh yeah, very top, view options, annotate. Yeah.
Okay, yeah, got it. Cool, thank you.
Okay, this will be handy because then we can make it a two-way experience.
Sweet.
So clearly in the lateral compartment, I'll start by annotating here. We can see something there, and we can see something there.
Yes.
What do you think you're looking at?
So the first line is pointing to the peroneus brevis tendon, that black dark circle. And then more posterior right behind that is the longus, I believe.
This one's a little tricky, so I'll go back. Okay. I'll apologize for the trickiness to start. But when you're looking at the lateral compartment, which one is going to originate higher up?
The longest. The
longest will, right? So by the time you have one thick, healthy tendon, which one is that going to be?
By the time you have one healthy tendon, that would be the longest then.
Good. So if we're seeing one large tendon, it's like that's the longest. And if we're only seeing a formation of the tendon, then that's probably the brevis at this point.
Okay. All right.
So then if you want to move anteriorly, some things we can tell are we have a tendon right here. Do you know what that one is?
That's the tibialis anterior.
Okay. And then what comes next?
Next is the extensor hallucis longus.
Good. And then what are all these ones in here?
Those are the extensor digitorum longus tendons.
Good. And as we get a little bit further, we'll be able to see the neurovascular bundle originate a little bit more. But do you remember where, between which two muscles does the neurovascular bundle originate? So it's right here, right now, and eventually it's going to move its way out.
Okay.
If you want to pass, the next person can take that one on the next slice.
Sure. Yeah, I have a guess, but I'm not 100% sure, so I'll pass on that.
So other things, what is this muscle back here that has formation of tendon?
Okay, so so we're still high up.
Remember, what's the most lateral muscle in the deep posterior compartment?
Yeah, that would be the flexor hallucis longus.
Good. And then you can't really discern right now, but what two muscles and tendons would be in here?
Should be the tib post and the FDL.
Good. And then right in here, you can see the neurovascular bundle.
Mm-hmm.
Okay. Who wants to take the next slice here?
Dr. Rosante, can I ask you a quick question?
Absolutely.
So just back to the lateral compartment, I guess I was just used to the longus always being, or excuse me, the brevis always being closest to the fibula, but I guess at this level you're saying it's just that thin, wispy thing most posterior.
I'm trying, let me clear my drawings here. It's easier, so we can do still shots pretty easily, but sometimes it's easier to see scrolling, and if you actually see me scrolling through, let me get out of the annotation part here. So if we look at the difference between these two slices, what we can see is right here. Can you see my mouse?
Yes.
So this is the peroneus brevis muscle originating lower, and see the slip right here?
Yeah, I do.
If we go back one slice, that's just right here. So basically the muscle is really starting to form out this way.
Mm-hmm.
And then as we get closer, there's no muscle left of the longus and the brevis is getting smaller. So you are correct in that once we see both, this is the brevis muscle that's starting to originate off the fibula here. But remember, when you feel your own leg, there's nothing coming off the direct lateral surface of the fibula. It's all posterior part. I don't know who's got the background noise.
I'll mute my mic.
So this is really the brevis we're starting to see, and as we go one slice lower, you can really see the brevis starting to take shape here. So you are correct. All right, who would like to take this slice? Everything is pretty much answered. There's only going to be a few other things that we're going to talk about.
I can do it.
Okay. So starting off with the bones, what bone is this?
Still the tibia.
Good. And then your fibula is right here.
Mm-hmm.
And we went through everything else as far as tendons. Nothing else has really changed except you start to see everything separate out. So right now, what muscle and tendon is that one?
Post-tiv and like I'm Dick and Harry.
So which one specifically? Oh, this is one of them. So we see one that's just
posterior,
yeah, posterior tib. You see only the tendon, and then right posterior to that, you see the flexor digitorum longus with a little bit of muscle right there.
Yep.
And then what's the whole bundle that's right behind it?
Like tibial nerve, posterior tibial artery.
Good. So your posterior neurovascular bundle is right there.
Hmm.
Other things we can see is as we come, sorry, my mouse disappears, so I'm trying to draw blind. Right in here, what nerve might be in that little bundle?
Like sural.
Good. And if we come more anterior, you can start to see what's in there.
Like anterior tibial, maybe turning to dorsalis pedis.
Okay, good. Yeah, I'm
Yeah.
okay if you just say your anterior neurovascular bundle.
Yeah.
So that's why when you actually look at it and we see right here, which tendon was that one?
EHO.
Good. And which tendon was this one?
Antip.
Okay. So if you're doing an anterior ankle surgery and you want to cut safely, whether we're doing maybe an ankle replacement or an ankle fusion, if you can identify the anterior tib tendon and the EHL tendon, you can safely make a cut in between those two. But if you're going more lateral and going lateral to the EHL tendon, then you're going to get into your neurovascular bundle there. So it's not a safe zone. If we can see a little nerve right in here, what would that be?
Saphenous.
Good. Okay, who wants to go next?
I could go next.
Let me clear the drawings here. Okay, now we see a few more bones. Still don't know why I can't get my mouse here. There we go. All right, what bone is this one here?
Talus.
Good. What do we have here?
The medial malleolus.
Good. And what's this one?
Lateral malleolus.
Okay. So we can see which tendons right down here.
The peroneal tendons.
So here's our longest that we don't have any muscle left, and here's our brevis right there. And can you see this really thin black line that originates right here?
Yeah.
What would be a thin black line that's going to go right over top of those muscles?
So the retinaculum.
Good. Okay. What muscle is this down here?
That would be no.
Still same deep posterior compartment.
Flexor hallucis longus.
Good. Here's the remnant of your soleus, and the Achilles tendon is starting to take shape here. Here's your neurovascular bundle, like we pointed out earlier. And which tendon is this flatter one here?
Posterior tibial.
Good. And what's this one?
Flexor digitorum longus.
Okay. As we move out anteriorly, kind of everything along the same way. If we're going to, I think one of the only major nerves, if you want to split in quadrants and remember where all the nerves are, we had which one's back here?
That'd be sural.
Good. What's over here?
Posterior tibial.
Okay. What's over here?
There's saphenous.
Okay. And then what would be over here, a smaller one that's really hard to see? Yep. Finish saying it.
Superficial peroneal.
Okay, good. All right, who wants to go next? We're moving down a little bit closer.
I'll go.
Okay. So which bone is this one right here?
Calcaneus.
I'm going to go back. So this was the ankle joint, right?
Yeah.
So you'd say this is an axis with a level ankle joint. What tendon is back here?
Your Achilles.
Okay, so does it look like that's inserting the calcaneus yet?
No.
Okay, what would this be?
The talus.
Good. Besides the talus, what's the only other bone that you can see here?
Your lateral mal.
Good. So the tip of your fibula is right here. And what did we just mention before that you can see this nice thin black line here?
The retinaculum.
Good. So if you see this ruptured or you see the peroneal tendons out, what do we call that?
Perineal subluxation.
Okay, good. So that's what you'd be looking at for that. And what tendon is sitting right here in the back of the talus?
FHL.
Okay, and what's out here?
PT.
What
and
would this be?
FHL.
So which is which? Which one's more?
PT would be up higher.
Good. There's your PT, and there's your FDL. So think about if you are making an incision on the medial ankle and you go through the skin, what might we get to before you even get to the tendons? What's this thin black line right there?
That'd be a retinaculum also, right?
Sure, which one?
The flexor retinaculum.
Okay, good. So you make your incision, you go through the skin, you go through the flexor retinaculum, then you see your tendons. And then what do we see right here? So what would you, if you're, think of your dissection, skin, retinaculum, tendons, then something else before you get to bone.
Be like a bursa or something?
Not a bursa, something anatomically that's going to hold the bones together.
Oh, a ligament?
Yeah, which one would that be over here?
That'd be your deltoid ligaments.
Good. And then on the opposite side of the leg, when we have this going from the fibula to the talus and it's broad and flat, what would this ligament be?
PTFL.
Okay. And then see this one that's more thin and cord-like?
Mm-hmm.
What would that be?
What's it? ATFL.
Good. So if you're ever looking at an ankle sprain, you want to get to this axial image and you want to be able to see the fibula and the talus and see what the ligament looks like going there. Okay. Who wants to go next?
I can go next.
Okay. So we're going to start off by what bone is that?
Calcaneus.
Okay. We're going to keep going down the line. What's there?
Cuboid.
Okay. What's that one?
Navicular.
What do you think is that is right there underneath the structure? What bone is that?
Is that the sustentaculum?
So sustentaculum is,
Medial.
you're close. Let me get my mouse back here. It keeps disappearing on me. So this, what's the structure running right here?
Is that the spring ligament?
Yeah, there's a spring ligament. So what does the spring ligament support? What bone would be right underneath here?
Is that the talus, like the bottom?
Yeah,
of
so see right here the navicular, this has got to be the talar head. You're getting
okay.
a little bit of the talar head you're visualizing, and then getting the spring ligament right below it. So that's a good supporting image there.
Okay.
And then what bones do we have out here?
Your cuneiforms.
Okay, and then what are these three?
Bases of your metatarsals.
Okay, and what ligament's going to be right here?
Your Lisfranc.
Okay, and then when you see these two little thin black lines, let's say they're going to be small little tendons. What tendon would insert right here and out this way a little bit?
Peroneus longus.
Good, and then what about over here?
Tibialis anterior.
Okay, good. And if we're looking at your tendons down here, which one is this one going to be?
Would that one be FDO?
So right here is your, see this little part right there?
Is that the sustentaculum?
Correct. So what's underneath it?
Okay, so FHL.
Good. And then what's right here?
FDO.
Okay, and then what's right here?
That'd be your TP.
Good. And if we go back, once we flip and go around the lateral mal, which one of these tendons is going to be more posterior of the perineals?
It'll at that time it should be your longest, shouldn't it?
Yeah, so this bigger one's the longest because where's that going to dive?
Underneath the cuboid.
Yep, exactly. And then your brevis is going to be more distal and go right to the met base. As far as where the FDL and FHL tendons are, yeah, let me get an arrow here. Actually, let me try this. The first circle there is our FHL running underneath the substentaculum. This is your FDL running adjacent to it, and your PT tendon there. When we're getting tendons that curve a lot more, unlike the axial images beforehand when we're getting them in a perfect cross section and you can see a nice cylindrical tendon, once they start to take turns, we're going to see it look more gray because we're going to get more oblique of an angle there. Okay. Who wants to go next? Let me clear all my drawings off. I think this is our last axial image. Let me check. Yep.
Go back to that one before that,
Yes.
please.
Yes, sir. There you go. This one?
Yeah, so who knows what this is? Oops, that was pretty bad.
Perineal trochlea.
Okay, so that's how it's a good anatomical landmark when you're trying to figure out where the perineals are running, right? So the perineus, that's where that divides, right? That sheath divides. That's where you can find those tendons. That's all I got.
Nice. Let me clear. While I clear this, everyone can decide who's going next.
I'll go again if no one wants to go.
Okay. So what we're seeing is, let me get my annotation back. It's an axial view, and where are we in the foot?
Looks like we're plantar at the level of the med head.
Okay. So when we're identifying here, which is the only full metatarsal we can see?
The fifth.
Okay, good. And when we're looking, we talked about the calcaneus the other day, right? Last week.
Mm-hmm.
So which tubercle is this one?
Your medial tubercle.
And then this one is?
Lateral.
Okay, so that's why on an x-ray, when we look, we can see the medial one more prominent and more plantar, and the lateral one's just going to be that little remnant that looks more radio-opaque on the x-ray.
Mm-hmm.
What tendons do we have running out here?
Is that the most medial one? Would that be like your FHL?
So that's the FHL, and then these are what?
Your FDL
Okay.
branching.
And what do we have going on in this region right here?
Is that your knot of Henry?
Yeah, because we don't see, if you're describing it, we have an increased signal intensity, or it's hyper intense compared to muscle, or hyper intense compared to tendon.
Mm-hmm.
And this is a T1 image, so it's going to be more fatty, fibrous tissue that's going to light up. So there's a little knot where everything comes together. And if we're looking more proximally, we have a few little muscles. This is a hard area to identify some muscles, but you can kind of tell based off the way things are running, what might be running. What do you think that muscle would be?
Is that your FHB?
Good. See how the FHL is in between the two?
Mm-hmm.
And what could that one be?
Abductor lucis.
Okay. And if there's a muscle that we talked about that's kind of deep right in here that should be inserting on your FDL tendons, what would that one be?
Your quadratus plantae.
Okay. And then it's hard to tell fiber-wise if we have any of the flexor digitorum brevis tendons or muscles, but we know that we're deep to that, right? So we probably shouldn't see anything because we're already seeing what layer is all of this going on in.
Your second layer.
Good answer. And then up top here, you might be able to see some fibers that are running a little bit in a transverse direction. What do you think those would be?
Your adductor hallucis transverse part.
Okay, good. And then maybe something all the way out here. What would you call that one?
If we're in this layer, I mean, if we're already past the second layer or in the second layer, so I would say, is that the flexor digiti minimi?
So the tricky thing about that is, yeah, this is a hard one. That's why I say that one for last. It could be either or. If it's coming off of the calcaneus.
Oh, that's right.
Abductor, right?
That's right. Yes.
Yeah. So your flexor digiti minimi may be this little muscle belly out here, or that may be a continuation of the abductor, just depending on where everything is. But you wouldn't be expected to identify any of those. It's just more of understanding the anatomy of where everything is.
Okay.
So good job. All right. Who wants to take on the first sagittal image? Anybody?
I can give it a shot.
Okay, good. So the sagittal view, right?
Mm-hmm.
The first thing you have to do on a sagittal is identify, are we more lateral, more central, more medial? So can you identify any bone here?
It kind of looks like the cuboid. So
Good.
we're lateral.
There's the cuboid, right?
Yeah.
So we are lateral. So once you know you're lateral, if that's the cuboid, what bone is this?
That would be the calcaneus.
Good. And what bone is this?
The fibula.
Okay, good. And does it look like this bone right here is the fourth or the fifth metatarsal base?
I would go with more the fourth.
You're correct. Why is that?
Because the fifth has that tubercle.
Yeah, exactly. So you're right on track. And then here you would see your third metatarsal and lateral cuneiform. Good. So you've identified all the bones. Good job. What muscle would this be? It's the only muscle we haven't really talked about so far.
It would be one of the extensor brevises, and since we're more lateral, probably digitorum, extensor digitorum brevis.
Yeah, we also know that's the only muscle on the dorsum of the foot, right?
Mm-hmm.
Everything else is extrinsic besides your interossei, which are technically considered plantar muscles. So any dorsal musculature right there is going to be your EDV. And then what do we see coming back here?
The Achilles tendon. Or no, because we're lateral.
Mm-hmm.
That'd be one of the perineals.
Good. So we have perineal tendons. You can kind of see a little bit where they're starting to split here, but it's not a good enough slice to be able to tell. But what you can tell is what is going on right here.
Is that the around the cuboid?
So follow this.
Is that peroneus longus?
Yeah, it's peroneus longus where it's taking a turn and going underneath your cuboid, because once it takes a turn, we get it more cross section there, and then it's going to go towards the first met base. So you can't identify that.
Okay.
Good. All right, who wants the next one? So to go over terminology for when tissue looks lighter or darker on the MRI, there's different ways of talking about this. So if we're looking at the tibia right here, you can say there's an increased signal intensity, which means that there's more fat here since it's a T1 image. On an increased signal intensity for a T2, it would look bright because it's water. So you can say increased signal intensity. If you're going to compare tissue, you would say that the tibia is hyper intense compared to the muscle posteriorly to that. It's also hyper intense compared to the tendon. You can say that the tendon is hypo-intense compared to muscle or compared to bone. And sometimes if we're talking about describing something different, like a mass or even whatever's back here, which someone's going to answer in a second, this tissue is iso-intense to the tibia, meaning that it's a high fat content on this T1. So if you are considering identifying a soft tissue mass or a cyst or a lesion or something like that, iso-intense can allow you to identify what the material is because it has the same signal intensity as something else. Sure thing. All right, anybody want to go?
I'll go.
Okay, so you've got the tibia. What's right below it here?
Talus.
Good. What's right below that?
Calcaneus.
Good. What's this bone here?
Navicular.
Okay, and this one would be?
Medial cuneiform.
Yeah, it's hard to tell. What would we look for distally to tell if we're all the way at the medial cuneiform?
First met base. Or
Okay, so do we see sesamoids underneath there?
kind of looks like it.
Yeah, maybe there is. Sometimes if we have a good slice, you can tell. Here's a sesamoid right here. So if we're not all the way there, then we're okay. You would scroll through normally, but it's probably not the first because there's no sesamoid. So we're probably at the second, which may make that an intermediate, or if it's the third, a lateral cuneiform. We probably are looking at the second because what part of the calcaneus do we see here?
Starting to see sustentaculum in there.
Good. So we know we're more medial there, right?
Yeah.
Okay. When I mentioned a bit ago, what material or what do you call this tissue?
Is that the retrocalcaneal bursa?
If it was a bursa, it would be fluid filled, right?
Right. So
how would we describe that compared to bone? Choices are hyper-intense, hypo-intense, or iso-intense compared to bone.
ISO.
Good. So if it's iso-intense compared to bone, that means it's all fatty there. So what kind of fatty tissue is there?
Not sure. No.
In the chat room, someone suggested Kager's triangle.
Kager's, yeah.
So there you go. Kager's triangle in there. And when we talk about Kager's triangle, there's 3 borders to it. So what's the inferior border?
The top of the calcaneus.
Okay. What's the posterior border here?
The Achilles tendon.
And then what tendon is running right down here that can make up the anterior border?
Is that the FHL?
Good. So you identified the Achilles tendon. See how nice and thin it is along here? So that's a normal, healthy Achilles tendon. If we have somebody with tendinosis, it would be thickened, or you would see what looks like increased signal intensity in the middle of it, which can present as mucoid degeneration or Achilles tendinosis. What's going on down here? What is this tissue?
The plantar fascia.
Okay, good. Who wants to take on this one? Can you see it on, let's see, Clarity said, let me clear this out. So what small accessory bone good. We've got some people in the chat room. Okay, everyone's got it. Os trigonum back here. Sometimes we have an enlarged lateral process of the talus, and that can be fractured, and that's the stitus process. So, if it's symptomatic or not, sometimes the radiologist will read it and say, it appears symptomatic or not or asymptomatic, they can kind of tell based off on a T2 image if there's a lot of fluid or a lot of inflammation around it. We may be able to tell that it's a pathologic bone. Otherwise, if it looks pretty calm, it may not be bothering the patient, but you'd always correlate that clinically. As a follow-up to how you'd correlate that, what would you move on a patient in their clinical exam to figure out if that's painful? Good. So you'd move the hallux, which is moving the FHL. All right, I'll pause so Dr. Clarity can answer his questions or ask his questions.
No, just kidding.
Okay. All right, who wants this one?
I can go get it if no one wants to go.
Okay. So we've identified where we're at, right?
Mm-hmm.
First metatarsal sesamoid. So if we know we're all the way medial, what's this right here?
Sussentaculum tali.
Okay, and what ligament would run right here?
Spring ligament.
Okay. If we're at the sussentaculum and we see this tendon running right there, what would that be underneath?
That would be the FHL.
Good. And what can we see that's kind of in this zone here?
Would that be the FDL?
FDL would be up here, adjacent to the FHL. Or sorry, adjacent to the sussentaculum tali.
Oh, that's right. It's running underneath the FHL. Oh, would that? No. Not sure.
So if you're looking at the tissue, how would you describe this tissue right in here?
Yeah, it's darker. It's
Okay. I'm okay with that. Darker is good. So darker than what?
It's darker than. It looks almost as dark as a tendon.
Okay. So you're going to say that it's hyper or hypo intense compared to bone, right? So instead of just saying darker, compare it to something.
Okay.
You said it's almost iso intense compared to a tendon, but it's not quite. It's a little bit brighter, right?
Right.
So what could be running, if you know the FHL is here, what also runs down here that isn't bone and it's not a tendon?
Bone, not a tendon. It could be a ligament.
What else runs back that way that we covered in the, here, I'll give you, let's go all the way back here. So this is where we're looking. Here's your FHL, here's your sussentaculum, and then right here is where you're looking.
So that's, would that be the nerve in the back suture?
Exactly. So what procedure did we look at on Friday that you would make an incision here to release?
Oh, just a tarsal tunnel release.
Good, good. Last question, what muscle do you think this would be here?
Since we're pretty medial, I guess the abductor hallucis.
Good. And if you're looking at the talar dome for anything, you always want to look in this sagittal view to see if there's any sort of deficits here. A lot of times we have osteochondral defects there, and we'll cover when we get into the pathology portion. All right, last sagittal view.
Hey, Dr. Rosante.
Yes, sir.
Quick question. Could you go back 2 slides?
This one?
Yeah.
Okay.
Is that line on the tibia, is that the growth plate?
Yeah, it's a physeal remnant there.
Okay, that's it.
Okay. Good question. Whoever takes this one only has a few questions. I don't know if you can hear a dog barking in the background. I apologize. Well, Dr. Clarity, you want to be on the spot? We can put you on the spot.
I have to go see a patient in a second.
Okay, good excuse.
Thank
So we all saw Dr. Clarity dissect right in here the other day. as we made his incision, although he kept going all the way up here. He kept going and going and going. When we look at this medial aspect, do you want to ask some questions for a minute and then leave for your patient?
Sure. So what are the two structures that he just identified? So we're looking medially. So when we kind of looked at this with the x-rays from last, correct, yeah, so the anterior and posterior colliculus, which are important with looking at for MRIs or with CT scans to see where that fracture is. You know, in the case of a medial malfracture, where the fracture is, so you can place your incision appropriately for fixing it. And you can see here, even better than the x-ray, how the anterior portion lies more distal or lower than the posterior colliculus. So, which again is important in trying to identify when you have, you know, some kind of pathology going on. You're trying to identify which portion is affected, whether it's anterior or posterior. All right, so the mouse right now is overlying which tendon? Yeah, that. I guess I can draw. Looking at going. Good, the posterior tibial, right? Which is one of the things we identified Friday with the cadaver. So that posterior tibial tendon runs directly, you know, through that posterior portion of the medial mal. So it's very easy to find that tendon as it runs down, right? So you have your posterior tibial tendon running along and then attaching down distally to the navicular, and then its other branches too. So if you follow that down, what I think Dr. Rosante was drawing there, what bone is that identified as attaching to? Good, right? So, yep. So we're looking at the navicular at that point, and then distal being your cuneiform and first metatarsal. And again, you can, you know, I said this earlier on in the chat, but it's very important to just kind of look at the whole picture to find out where you are, because you can use, I call them context clues, although that's not appropriate for this, but using clues around you to figure out where the heck you are. Because, you know, sometimes on externships, they'll just give you this slice, or on interviews, they'll just give you this slice, and you don't have the ability to scroll back and forth and figure out, okay, now I'm medial and now I'm lateral, but you can use these little clues. You know, this is clearly the medialmost portion of the midfoot and the distal forefoot. So you know that this is, you know, medial mal versus lateral mal, because this kind of looks like a lateral malleolus. But because you have the sesamoid, the first metatarsal, and then the navicular, you know that you're not laterally, but rather you're medial.
Yeah, and the only other thing that you can identify here is you can actually see some of the deltoid coming off of the tibia there. All right, let's see your patient.
You can come get me up.
Okay, we've got a few axial. We've got about 3 axials to go through. Anybody want to start? So on the first one here, I'm sorry, not axial, coronal. We have coronal images to go through. So if we're looking at the coronal image, we can clearly see some bones here. Who knows what bones those are? Or where at the level of the forefoot are we? Good, these are the metatarsal heads. There's the first metatarsal head, right? So what runs right underneath it? Sesamoids, good. besides this, the metatarsal heads, what's this little bone out here? Good, the 5th proximal phalanx, good. And what tendon is gonna be right in here? FHL, very good. You can see some of the abductor hallucis tendon coming down here. And maybe a portion of the FHB here that's gonna be coming out and go into the proximal phalanx. If we're looking up top and trying to identify some of the tendons, if we see, we'll look at the 3rd metatarsal right here. If we see one tendon coming from directly over the midline of the metatarsal and one coming from a little bit lateral, which one of those is the extensor longus versus the extensor brevis? Good. EDB is from lateral. Wow, that's bad. And longus is straight dorsal. Good. All right. If we're moving a little bit more proximal, you would say this is a coronal T2 image at the level of what? Yeah, we can start to see some of the first met base here, but really the metatarsal shafts. So this gives you a lot of anatomy to look at. And we can see a bunch of different things here. So when we talk about tendons, if we see a small tendon that's more superficial than a deep tendon, which one, what is that going to be? So think about your layers. Flexor digitorum brevis, right? Because it's in the very first layer, it's the most superficial muscle and then tendon. And then right here in the second layer would be your flexor digitorum longus tendon. So when we're actually identifying everything in here, it's important to remember, I'll go forward one slide so you can see, your interossei aren't until you get all the way up to the metatarsals because that's where they originate. Everything else is much lower. So when we're looking in here, if you do have, I'll give the cheat sheet here so everyone can see. If you do have the FDL tendon here, remember the lumbricals come off of those in layer 2. So those are going to be much lower at this point. And up top, so everyone's getting tired, I know. So we'll kind of just go through some things instead of having people verbalize. We'll just go around here. You can see your abductor digiti minimi on the outside and your flexor digiti minimi brevis. When we're getting into your abductor hallucis, it's kind of hard to tell in this big jumble in the middle, but you should just at least be familiar that layer 1 is going to be your FDB, layer 2 is going to be your FDL, and then you're going to get into your adductor hallucis and some of your flexor hallucis brevis coming out towards your first ray. And your lumbricals are in layer 2. Your interossei are going to be in layer 4 here, where you have your plantar interossei and your dorsal interossei. Technically, the only dorsal musculature is your extensor digitorum brevis. Anyone, this is our last one. Does anybody want to step up and do an ankle coronal image?
You can do this one.
Okay. So what bones can you identify here?
So you got the tibia, fibula, the talus, and calcaneus.
Good. Tibia, fibula, your talus below, and your calcaneus here. Do you think you're at the anterior aspect of the ankle joint or the posterior aspect, and why?
More anterior with the subsentaculum tali there.
Good. It's all using your context clues. So we know the calcaneus narrows more anteriorly, and we have the subsentaculum anteriorly. So good. You're at the anterior ankle joint. So what tendon is right below it?
The FHL.
And what would run right next to it?
Yeah, FDL, and then
Good.
tibialis
And then,
posterior.
yeah, you'd have your posterior tib right there. What kind of tissue are we seeing right here that's going from the tibia to the talus and even further down to the calcaneus?
The deltoid complex over there.
Good. So you can see that it's all at an oblique angle there. So it's not going to look nice and pristine. What can we see muscle-wise in the plantar foot?
The abductor, like first layer, like abductor hallucis, and the FDB, and then the abductor digiti midi.
Very good. Sorry, someone wants to see the deltoid again. So going from the tibia to the talus and even some parts down to the calcaneus there, this is all the deltoid in there. You can see that thin layer we talked about beforehand. See this thin black line? There's your retinaculum, and then your tendons, and then your deltoid, and then your bones. So just always think anatomically what you have to cut through to get down to bone. What muscle is right in here?
The quadratus plantae,
Good.
I think, yeah.
And what two tendons are right here?
And the peroneal tendons.
Okay. Which one do you think, if we're right underneath the fibula, they can kind of be twisting right now, so it's a little tricky, but what do you think would be the bigger one right here?
The longest?
Yeah, it probably is, but I wouldn't expect you to know that without scrolling through. If we're looking at the tissue, what ligament would run right there? If we're at the anterior.
That's not the anterior fibular talar.
All the way down to the calcaneus, right?
Yeah, not CFL.
Good. So you might get a little bit of a portion of that, but it's not the best view. The best view is what we looked at on the axial image. What I do want to point out is when we're looking in the joint, so you see this white bone, I drew it on the remnant there, all this white bone there. What kind of bone is that?
Not the starts with an E.
What generalized type of bone is all this white bone?
Oh, cancellus.
Yeah, good. And then what about this black line right there?
And the cortex.
And then what do you think this gray is?
The subchondral.
What's right above cortical bone?
Periosteum.
Don't look at.
No.
Is there periosteum in a joint?
No.
It's cartilage.
The cartilage.
And then you can then see on your talus cartilage, maybe a little bit of subchondral bone, and then cancellous bone. So you can see all the layers in the joint if you look in those certain areas.
So we can see like OCDs, but you said like on the sagittal view, it's better.
On an axial view and a sagittal view, those are the two that are helpful to see them. So when we get through pathology portions of anatomy, we'll look at those. But you want to at least be familiar with the layers going from cancellous to cortical to cartilage, and then back down as you go through the talus.
Okay, nice.
Good. All right, so I want to just show you guys as well. So Kent State now gives us access to this website, IMA iOS eAnatomy. And this is a great website to just scroll through everything to test yourself. There's an app where you can look at it on your phone. Again, you can't recognize pathology unless you know real anatomy. So make sure you're going through and spending time to review this. It's a really good website to review. All right, we're just about done here. I will send out instructions of how to view this in the recording, and then I'll send out a little link to test yourself with a quiz on MRI anatomy, and then we'll go over those answers next week. The other thing is we're waiting to figure out if we have a cadaver limb for this Friday. So hopefully this afternoon, or if not by tomorrow, we'll send out instructions for Friday's workshop as well. So thank you all. Enjoy your week.